All right, everyone, it's 8:30, so we're going to go ahead and get started. Again, good evening, everyone. My name is JD McLeod, and I'm the Digital Engagement Coordinator here at Fear Free, and I will be your host and moderator for tonight's Fear Free Top 5 and 15 webinar. We are thrilled to have you join us, and we'd like to extend a warm welcome to all of you veterinary students attending today's presentation on the top 5 pitfalls of the emergency room with Dr. Tony Johnson. Before we dive in, I'd like to share a few quick housekeeping notes. Your microphone will remain muted throughout the presentation to reduce background noise. If you have any questions, please type them in the chat. We will do our best to address as many as possible at the end during our brief question and answer. A recording of this webinar will be made available to all attendees within 2 weeks and will be sent directly to your email address. This webinar is a part of our Top 5 and 15 series brought to you by Fear Free, where we aim to provide you with quick, actionable insights that help you better prepare for your future in veterinary care. Fear Free's mission is to reduce fear, anxiety, and stress in pets by educating the people who care for them. If you're interested in learning more, you can visit fearfreepress.com, and don't forget to follow us on social media at fearfreepets for updates on future webinars. The Top 5 and 15 series is also brought to you in part by the Veterinary Business Management Association. And Dr. Tony is so excited to speak with all of you. Before I bring Dr. Tony onto the stage and he can share all of his knowledge with you, I want to give him a quick introduction. We are incredibly fortunate to have Dr. Tony Johnson with us today. Dr. Johnson received his DMV from Washington State University in 1996 and became board certified in the shadowy specialty of emergency medicine and critical care in 2003 after doing his residency in Portland, Oregon. He is currently an ER specialist for Noah's Animal Hospital in Indianapolis and Minister of Happiness for VIN, which means he tries to keep all 300 of his consultants happy and connected and productive. And he also is in charge of mimosas and bellinis. He used to live in a converted one-room schoolhouse in the middle of a cornfield, but his family has since taken up occupancy in normal houses in a normal neighborhood with very little corn. His wife and him share 2 sons and 1 daughter. His wife, Gretchen, is also a criticalist. His favorite shape is a trapezoid. In his spare time, he enjoys sleeping, eating, breathing with occasional forays into woodworking, wine, movies, raising a family, cooking, drinking whiskey, raising chickens, reading, and writing, but not arithmetic. Without further ado, I would like to introduce Dr. Tony Johnson as he presents to you. Yes, Dr. Johnson, we can see you.
Okay, nice. Thank you guys for being here. Thank you for the introduction. Makes me seem more respectable than I actually am, JD, but I appreciate it. So I'm actually in the ER right now, and it's a busy night. So there is a small possibility they're going to come grab me and have me go treat a trauma case or something. If that happens, I'll bring the webcam along and you guys can see it. But let me venture into the 5-ish pitfalls of emergency medicine. I cheated a little bit and threw some extras in there. And I know y'all are students, so if there's anything that you need clarification on, let me know. I don't think I can really see the Q&A right now, but feel free to pipe up and I'll try and answer whatever I can. So the idea behind this lecture is I wanted to take things that I had seen over the years that I really wished I knew a little bit more about going into it. So each item is kind of culled from now 28 years of ER work. And all of these things I have messed up at some point, and I continue to mess up. So learning is a lifelong process. I try and always improve and read papers and talk to practitioners to improve what I'm doing. But I've messed up all these things at one point. So these are really either clinical signs, test results, conditions, or something on your exam that can kind of mess up your day in the ER and be like, oh, I didn't see this thing coming. And the whole idea is for those of you who are in general practice, or those of you who are going on to either ER or specialty practices, to kind of help a patient before you may send it on down the road to the ER, or if it's a patient who you're taking care of to help you manage that patient in your ER or referral practice. So we'll start a little bit slow, urinalysis and culture. And one thing that I think happens a lot as you get out, and I'm as guilty of this as the next guy, is in school, you're going to have hammered into your head that the holy trinity of kind of a start of a workup is a CBC chemistry and UA. And the urinalysis is one of the first things that you will pitch or not do when you get out, because one, you'll get some pushback from owners who will say, well, there's not any urinary tract, obviously, problems. Sometimes it's hard to get a sample. Cystos are not without their risks, and you may have to drag out the ultrasound. So one thing I would tell you is if you're just looking for, say, a garden variety urinary tract infection, or you just want a UA to kind of complete the minimum database, a free catch urine sample is almost always fine. So if I have a patient where they've had resistant UTIs, we're worried, we may have to culture it, then you do need a cysto sample. But just for your, garden variety patient, a lot of times a free catch urinalysis is important. And where I think the UA is really helpful is, let's say a patient is referred to an ER for care. It's been, vomiting, maybe an increase in water intake, and there's some azotemia on the initial blood work. So that means the renal values, the kidney values are elevated. Well, that may just be dehydration. And what the body does when it's dehydrated is tries to conserve water. And when that happens, the kidney values can sometimes go up. So I hope I'm not talking at a level that is either way too basic for you guys or way too advanced. I'm not sure what the spread is of the students here, but, like I said, if there's terms that I'm using or whatever that are confusing, just let one of the handlers know and they can break in. But pre-renal azotemia is when you have a patient who is so dehydrated that their kidney values are elevated. Intrinsic renal means there's something wrong with the kidneys themselves, like chronic kidney disease.
Dr. Johnson, one second. We have a couple students that said they can't see your PowerPoint.
Oh, boy.
Yeah.
Okay, let me back out of this. So
everyone, we're going to address that issue now.
Yeah, that's fine. I think I shared it. Let's try. Because I think what I did before was this. And then share.
Okay, we can see now. Can everyone
see it now? For sure? You can see it?
We can all see it.
Okay. All right. Well, let me just go back to where we were, UA and culture. So I'll kind of cut to the chase on this one. Urinalysis is an important part of the basic workup to help identify, are we just dealing with a severely dehydrated patient, or is there something intrinsically wrong with their kidneys? The other thing that happens all the time is if you have a sick diabetic patient, let's say it's a known diabetic and they've been puking for a couple of days and they come in, they may have gone into a more severe phase of diabetes called diabetic ketoacidosis, which I have one of those in the hospital right now. And unless you do a urinalysis, you run the risk of not being able to pick up ketones, which have implications for the length of hospitalization. It might change your management. So ketonuria in a sick diabetic is important. All sorts of other things. Pyuria is pus in the urine, proteinuria. So you don't have to get a cysto sample all the time, but it is worth getting a urinalysis as part of your CBC Chem UA that you're working on. So just a little bit of renal physiology. Some of you guys may have had this, but this is stuff that really translates well to the ER and ICU in terms of how you manage patients. And urine-specific gravity is such a wonderful value to have, because if the kidneys are functioning well, they will concentrate the urine in the face of dehydration. That's what they're supposed to do. So if you lose about half of your nephrons, about half of your kidney mass that's functional, then the kidneys are still filtering out toxins, but they're not necessarily able to make concentrated urine anymore. And that number, the 1.008 to 1.012, is what we measure on a refractometer. And it's just basically how much stuff is in the urine that's not water. And so concentrated urine, which is 1.012 or higher, means that your kidneys are functioning pretty well. Once you get to the point where about 3/4 of the kidney mass is not working, that's when the toxins start to build up in the blood. And this is kind of a confusing but important point. So when you lose half of your kidneys, let's say due to old age, or like, in a person who goes and donates a kidney, your kidney filtering ability drops by 50% overnight. Your kidneys can still filter out toxins and do what they do. It's just usually you're making very, very dilute urine. Once you get to 3/4 of the kidney that are not working, then that's where azotemia develops, and that's elevations in BUN and creatinine on blood work. So that's the kind of the landmark for kidney failure. And you guys are going to see lots and lots and lots and lots of dogs and cats who come in, they've lost weight, they're drinking more, they're peeing more, and you'll pull blood work and you'll notice that their BUN and creatinine are very elevated, and that's azotemia. So one way that I'll use this in the ICU is if I have a patient who's hospitalized, let's say it's a dog who had a surgery for bloat, and I'm not quite sure if I'm meeting their fluid needs. If I get a morning urine sample and I check it and it's very concentrated, and by concentrated, I would say 1030 or 1035, which would be 1.030 or 1.035, then I may need to reassess my fluid therapy plan and see if I'm missing something. So concentrated urine in a patient who is hospitalized might tell you that your fluid therapy needs to be reassessed. And we'll talk about fluid therapy a little bit later. The more important point, and this applies across general practice, ER, whatever, is if you remember what I said, you have to have 3/4 of your kidneys not working before that shows up on blood work. So when you pull blood work on a 12-year-old dog and the kidney values are normal, that's great. Like I'm glad that they're normal. That does not mean that the kidneys themselves are functioning normally. So if we have concentrated urine and normal kidney values, I can say that's great. You got at least half of your kidneys that are doing what they're supposed to do. But I do think we do owners a disservice when we say normal kidney values on blood work means the kidneys are normal. That may be a little bit confusing, but that's an important thing. And then concentrated urine means we have at least half of the kidney function that should be there. All right, urinalysis and culture. So I'm sure I'm going to go through this pretty quickly because it's not, I don't think super interesting for you guys, but culture urinalysis on, considered a patient with an unexplained fever if you're going to do a full workup for them. Patients with urethral obstructions, although I would take that out for cats. Dogs with urethral obstructions due to a stone, you always need to culture them. But most bog standard block cats, studies have shown that really culturing the urine doesn't get you that much more info. A UCath is a urinary catheter. So a lot of times if that urinary catheter has been in for several days, we'll culture the urine when we pull it to see if they caught a bug in the hospital. And then acute renal failure, which has been renamed acute kidney injury. Acute renal failure patients, it's always a good idea to culture their urine in case they have an infection that's gone up there and infected their kidneys. The DKA that I was talking about, diabetic ketoacidosis patients, those guys should have a urine culture done. Chronic renal failure patients, some people will culture their urine every few months. But the one I want you to remember is if you see a DKA, so a diabetic ketoacidosis patient, these guys are usually very sick and would benefit from a urine culture. And if you're seeing the case and you're going to send it on down the road to an ER or ICU, it's a great urine sample and hold on to it, even if you're not going to run it. That way, when the next doctor gets this case, then they'll have the sample there before any fluids were given or anything. Okay, so number 4, this is a classic conundrum kind of threw in the other day because it's always a frustration. So the heart versus kidney debate. And what I mean by this is, let's say you have a 14-year-old Yorkie that's had a murmur all of his life, and we did some blood work before his dental a year ago, and now he's azotemic. So his kidney values are elevated, and we did a urinalysis, and his urine is very dilute. So he is in early kidney failure, and he has heart disease. If that dog goes into heart failure, the problem is the treatment for heart failure and the treatment for kidney disease are 180 degrees from each other. They're diametrically opposite. So what you have to do, so let's say this Yorkie who has borderline kidney function comes in and he's in heart failure. You need to give diuretics to get the fluids off of his lungs so he can breathe, but that is not going to do any favors for his kidneys. So this typically is not a battle that you can win. You can maybe play ping pong a little bit and go back and forth and improve the heart and then maybe improve the kidneys, but you have to try and pick which one is killing them right now. For heart failure, you have to dehydrate them. What I have seen a lot of people doing, which is utterly, utterly pointless, so don't ever do this except in maybe a few rare cases, is giving furosemide, which is a diuretic, so owners know it as a water pill, to get the fluids off the heart, at the same time giving fluids to help the kidneys. You can't, that doesn't do anything. That's like trying to put your car in reverse and park at the same time. When you are giving diuretics for heart failure, the kidney values are going to go up. And actually, I have a heart failure cat in the hospital right now who we're going to check some blood work on in a few hours. But I told the owner, don't be surprised if the kidney values are elevated. This is by design because we're trying to remove fluid from the lungs, but I can't do that without affecting the kidneys a little bit. Don't forget to allow your patients to drink as long as there's no reason not to let them. And then if you do go too far with the diuretics, which happens sometimes, you can do a little bit of fluid. What we usually will use is what's called half-strength sodium chloride, and we'll often give that subcutaneously. But really the main important thing here is to don't give fluids and diuretics together at the same time. You're wasting the owner's money. So I'm going kind of fast. I hope this is okay. I'm probably going to a little bit too. So JD, just let me know when you need to pull the rug out from under me, but I could keep talking for a long time. So number 3 is what's called the primary survey. And the reason I put this in here is I still, after doing this for a long time, when a patient gets brought in on a gurney, I feel my palms get sweaty. I feel my heart rate go up, and I need something to kind of make me chill and relax. And that something is what's called the primary survey. So the primary survey is what you do. And I had a hit by car dog tonight, mean as hell, Chihuahua. We don't know if he's got a broken back or what. But honestly, even something like a broken back, even though it's vitally important to the future of the case and to the owners, it's not what's going to kill that dog in the next 10 minutes. So what you do is what's called the primary survey. And you've probably been taught this in school. This is the ABCs. And ABCs stands for airway, breathing, and circulation. So it's very similar to what we do with when we're doing CPR. The S, though, which used to just be like the little possessive or whatever, now is part of it, and that stands for sugar. Because there will be, particularly in neonates, they may come in and their airway's fine, their breathing's fine, their circulation's okay, but their blood sugar is so low that they're going to die unless you correct that. So ABCs, you can expand that to be airway, breathing, circulation, and sugar. Non-life-threatening injuries, we leave those for later. So this dog that I evaluated, his airway was totally fine. His lungs sounded okay. His circulation seems okay. His gums were nice and pink. He's got good pulses. He's got normal body temperature. So anything we're going to take some pelvic rads. I think he may have some pelvic injuries, but this is not your initial priority. And this is where you kind of have to be the doctor, because the owners are going to be like, well, does he have any broken bones? And yes, that's important, but that's not important in the first 10 minutes. Also, I want you to be aware of something called a distracting injury. And that's when a dog comes in with a very dramatic, like open wound or road rash, or, the dog that jumped out of a pickup truck that's been dragged for 10 miles. Those dogs come in with incredible, gross injuries, but that's not what's going to kill them unless there's blood spurting out of it. So the distracting injury is something that takes your eyes off the prize and makes you forget that, oh, that dog also has a collapsed lung, or that dog is bleeding internally. So you really have to prioritize the ABCs, and sometimes sort of, not fight against the owners, but sort of realign them to what our priorities are, while also keeping them informed. So a lot of times I'll tell somebody like, hey, our initial priorities are, is there internal bleeding? Is there a collapsed lung? You have to use language they'll understand. Is there any impediment to breathing? And we're going to evaluate everything later once the dust is settled and we get pain under control and we get oxygenation under control, and kind of keep them informed. And you also, with a trauma case, you kind of have to let them know that sometimes we don't know the complete extent of the injuries within the first 12 hours. Like I've had some that may have a diaphragmatic hernia that may not show up for weeks sometimes. So prioritize the ABCs. Don't forget sugar. Don't get burned by a distracting injury. All right, so speaking of things you might find on your ABC exam, pneumothorax. So this just means an air leak into the chest. And when you're talking with owners, you are not allowed to use the word pneumothorax unless they're a nurse or an MD or something, because then you're going to sound like a doctor. And the problem is when you're, talking to these owners who may be, terrified, you need to find ways to make a connection with them and have them trust you, not ways to build a barrier. And one of that is through language. So we have to be compassionate with them when we can. We have to be understanding with them when we can. I try to sit down on their level. So I'll almost always take a stool in with me because I don't like to be, you know, the doctor standing up behind the exam table. The owners are sitting there crying on the bench. So I like to kind of be down on their level. If I can, I try to get down on the floor with the patient. It's often helpful to do your exam down there. I'll leave that up to you guys. But do not use the word pneumothorax with an owner. What you have to say is collapsed lung. They'll often get that because they've watched, you know, TV shows. So this is a radiograph of a dog with a pneumothorax. This is a lateral view, and if you see that black stripe there, I think that rad comes up later, but I'm going to go through it right now just in case it doesn't come up later. So there's a black stripe under that gray lump. I don't think I have a way. Can you see my cursor on there? Well, in any case, so the gray lump in the middle is the heart. The black stripe below is an air leak that has happened into the chest. So this dog has a collapsed lung, probably from trauma. So if you have a trauma patient that comes in that is having trouble breathing, and let's say it's 5 o'clock and you're going to send it down the road to the ER for overnight observation, I have time and time again see lots of patients that come up DOA because the referring veterinarian did not tap the chest. So if you have a documented pneumothorax, collapsed lung on x-rays, and they are in respiratory distress, don't put them on a bumpy half-hour car ride to the ER. Tap the chest prior to referral. And if we're going to tap and we think it's air, we're going to tap a little higher up towards the spine. If we think there's fluid or blood in there, we're going to tap a little bit lower. What I'll usually use is a needle connected to an extension set with a stopcock and a syringe. Shave and prep if time for trauma patients. And that means that maybe one swipe with the clippers, a little splash of alcohol, but you don't want to have your most anal retentive technician shaving up a perfect square and then scrubby like they do for surgery. So it's okay to stick a needle in the chest if you have a patient that is dying in front of you. If you can, so there's something called the neurovascular bundle, which is an artery, vein, and nerve, which is caudal to the rib. So if you can put the needle in cranial to the rib, that's great. I don't think you're going to cause a ton of problems if you happen to hit it, but just in terms of patient care and lowering the risk of bleeding, try and put it on the cranial edge of the rib. Now, sometimes either due to patient confirmation from obesity or they've got such bad chest trauma, you don't know where anything is, it's fine. Just stick a needle in there. We'll deal with the consequences later. So you don't have to tap the chest just because you have died of pneumothorax on x-rays. So if it's there, you want to watch their respiration very closely, but you also want to maybe document that with something like a pulse oximeter to make sure they're oxygenating well. And I just had this tonight. I had a dog who got hit by a car. I was a little worried about his breathing. I didn't tap the chest. I did do an ultrasound and I could see that his lung was adequately inflated, but his pulse oximetry is 99% on room air, which is great. But if this is a patient who is a trauma patient and he came in and he was really struggling to breathe, I would tap the chest right away and not even wait for radiographs. And then when I talk to owners about a collapsed lung, what I'll usually say is if we have to tap the chest more than 3 times in 24 hours, we probably are going to be needing a chest tube. And that's to keep the lungs reinflated so whatever is injured can seal over and start healing. But that's not a hard and fast rule. Sometimes you get a massive amount of air right away, and you know we're going to have to go right to a chest tube. Okay, number 2, pericardial effusion. This is another one that has burned me many, many times. So normally, if you remember from your anatomy, there's a little thin membrane sac around the heart, and it usually has a tiny little bit of fluid in it to lubricate the heart as it beats. In certain pathological conditions, the most common of which is cancer, the sac around the heart can fill with blood, and that sac doesn't stretch very much. So that puts pressure on the heart, and the heart then cannot fill with blood to pump it out to the body, and they go into shock very quickly. So what these patients look like is they're very shocky. It can happen suddenly. So this is sort of the classic, my dog was fine yesterday, doc, and now, you know, he can't get up and his gums are very pale. I think the neighbors poisoned him. So don't forget pericardial effusion exists. If you do get to the point where you take radiographs, sometimes it can be misdiagnosed as an enlarged heart, which is cardiomegaly. This is one of those diseases to suspect. And the more you kind of think about it, the more you're going to see it. So the clues that this may be going on, it's often older dogs. So for large breed dogs older than 8, bonus points if they have German Shepherd somewhere in the lineage, because they're very prone to hemangiosarcoma. The hallmark of this is typically acute collapse. So he was fine this morning. I came home and I found him kind of flat out. Pallor means pale mucous membranes. And one tip that somebody gave me years ago that has stood me in good stead is if you see a collapsed dog with pale mucous membranes and you check a PCV total protein, then you have to at least rule out pericardial effusion. Because if you think of what pale gums means, that means that the heart's not getting enough blood out to the periphery. And that can be due to blood loss. It can also be due to anemia, but it can also be due to the heart not being able to pump blood around. So there are lots of reasons for that, but one more common one is pericardial effusion or fluid in the sac around the heart. And if you miss that, it can be disastrous. Other things you may want to look for, there's something called electrical alternans, and I think, do I have the little circles here? This is very small, I'm sorry. But if you look on lead 2 of the EKG, you can see there's a small complex, there's a larger complex, there's a small complex, and that's called electrical alternans. And that's, I wouldn't stress about that too much. It really, you don't see it that often, but that's because the heart is swinging around inside this sac of fluid, and it changes how the tracing is on the EKG. The other one is called pulsus paradoxus, and this also is kind of hard to demonstrate. This is where basically the palpable pulse, so you're feeling the pulse, and when the patient breathes in, the pulse wave goes down, and that's because they're increasing pressure inside their chest, and that's going to make it harder for the heart to pump blood out. So pulsus paradoxus is when they breathe in and you're feeling their pulse and it becomes weaker. So the Frank Starling mechanism, this joke is getting dated because nobody knows who these two jokers are anymore, except for maybe Dr. Becker. But cardiac output is dependent on something called preload by what is called the Frank Starling mechanism. And all that really means is that the more blood the heart receives, the more blood it out, which seems kind of silly, basic. But what it means is when the heart is in this sac surrounded by fluid, it can't expand to fill with heart to push out the body. And so they go into shock very quickly because they're not able to get oxygen and blood out to the rest of their body. So veterinarians a lot of times have this thing where, oh, it's a heart furosemide or Lasix or a diuretic has to be in there somewhere. This is the one heart disease we treat with fluids. So unlike my CHF patient who I've got tonight, my congestive heart failure patient who I'm giving furosemide to, if I have a pericardial effusion dog come in pretty soon, we will give that dog fluids, which is the complete opposite of what you do for other heart diseases. So what really needs to happen is they have to be tapped. You have to stick a needle into the sac around their heart and either drain the fluid or allow it to drain into their chest. And this is fun to do. It's kind of a pucker factor 10 sort of thing to do, but you remove the pressure on the heart instantaneously. And these guys sometimes will jump off the table because all of a sudden their heart can fill with blood and they'll look way better in a very short amount of time. It's a really fun disease to treat. At the same time, we also give them fluids to help their circulation. The problem is a lot of these cases are due to cancer. So you may win the battle, but lose the war. And then kind of similar thing for hemoabdomen, means a belly full of blood. And in this one, I'm talking specifically about what's called a spontaneous hemoabdomen. The other variant of a hemoabdomen is a traumatic hemoabdomen, and that's where a dog gets hit by a car and has blood in their belly. And I don't know if I went into the details here, but dog that gets hit by a car that has blood in their belly, the vast majority of those will not need surgery unless they need surgery for some other something. A spontaneous hemoabdomen, which means the 10-year-old German Shepherd was fine this morning and he comes in and he's collapsed and now he's got a belly full of blood. Those really, realistically, our options are kind of hospice care, surgery, or euthanasia. So here's what one looks like on radiographs. And you could, I am going to go back to that radiograph. So I'll let that one fade away for a sec. But hemoabdomens are important because a lot of times I've seen referring veterinarians will either miss this or document it, but then not have an adequate discussion with the owners to let them know really what's going on. So generally poor prognosis and life-threatening nature of the disease for spontaneous hemoabdomens, totally different for traumatic hemoabdomens. So evaluate serosal detail on your film. So those of you who have had radiology probably know what that means. Presentation and signalment. So signalment is, this has probably been drilled into your heads, but age, neuter status, and breed. And don't be afraid to tap the belly. Ultrasound has totally revolutionized how we do this stuff, but you don't always need ultrasound to tap the abdomen. So let's look at that radiograph again. You can see in this region, there's an area, what we call ground glass opacity. So up on the upper right, you can see intestines, you can see stool in the colon. In this area where the yellow circle is, you can't see anything at all. So this is either bleeding or a mass. You can also see that like all of the giblets are sort of pushed up and to the side, so it's releasing other abdominal contents. And you may not have looked at a lot of rads yet, but as you get to that point, you'll be able to notice where things normally are supposed to live. So facts that you need to carry around in your head when you're dealing with these. So 10-year-old German Shepherd comes in, acute onset of collapse. You're doing your physical exam and you think there's fluid in the belly. You put the ultrasound on there. Yes, there's fluid. You stick a needle in it and it's blood. So that is your classic hemoabdomen. It can happen in any age or any breed, but in general, these are going to be much like the ones I talked about with the pericardial effusion, where they're older, large breed dogs, bonus points for German Shepherd, no history of trauma. They were A-okay the day before, and now they're dying. So if that happens, about 2/3 to 3/4 of those have a malignancy, have cancer, and it's usually hemangiosarcoma. So right here, and you guys are going to see lots of hemoabdomens. So just remember this, where acute collapse, older large breed dogs, fluid in the belly, and it's blood, about 2/3 to 3/4 of those are a really bad cancer. Now, let's say you're palpating the abdomen or you're taking rads because the dog's vomiting and you notice a splenic mass. It's more of a coin toss on those. So about 50% of splenic masses that are not bleeding are hemangiosarcoma. But those dogs that come in with a belly full of blood are about 2/3, 3/4 of them are cancerous. If we go in and remove the spleen, and it is hemangiosarcoma, so it's that 3 out of 4 dogs with cancer, not the 1 out of 4 with a benign process. Average life expectancy is about 3 months. And if you go visit your friendly neighborhood oncologist, you can often double that to 5 to 6. And some owners think, okay, that's great. Other owners say, I don't like those odds. And then we'll talk about either hospice care at home or euthanasia. Typically, we'll give them blood products. I need to take belly wrap out of there because that's really kind of fallen by the wayside. And then we do try to, if the owners want to go ahead on this, take them to surgery when they're either more stable or when the surgeon arrives. If you can get chest x-rays before surgery to look for evidence of metastasis, that would be a plus. But owner education is really important with these to let them know the very high likelihood that it's a malignant process that's going to kill their dog within 3 months. And again, I don't like to limit people's options. I tell them that and say, I've had dogs go as long as 2 years. These are all just statistics. This is not your dog. We can't predict the future, but they really have to know what they're getting into. All right. And in the 1 minute left, I'm going to do fluid therapy. I don't know if it's cool if I run over, but I'll just keep going until you pull the rug out from under me. So fluid therapy, man, there are a bunch of ways to approach this. And you guys are going to be taught it in your medicine classes. And then your mentors are going to give you totally different ways to do it. So nobody can really agree on we all have our own ways to do it. There really is not a universally accepted approach. So when we use fluids to treat patients, we're usually doing it for one of two things. We're either treating dehydration or we're treating shock and low blood pressure, which is hypotension. So I take a stepwise approach to my shocky patients. Crystalloids, which are your standard fluids that you guys are probably familiar with, LRS, Normasol, Hartmann's, that kind of thing. These are usually isotonic. The nice thing is they're very good at supporting blood pressure in a shocky patient. The downside is they do it for a very short time. So for a while, we had these things called colloids, which were fluids that had these big starch molecules in them that would stick around in the circulation for longer. Colloids are kind of off the market now because in human medicine, there was a association with kidney failure. So really, I should take that part out. And then pressors are agents that we use to constrict blood vessels in places where we've given a lot of fluids and we still have a patient who is in shock. And a classic example of this is a patient who's got sepsis. So overwhelming systemic infection. This causes all the blood vessels in the body to dilate. And you can give them fluids until the cows come home and you're still not going to get normal blood pressure until you give them something to constrict their blood vessels a little bit. And then for rehydration therapy, so the first use I said was for treating a shocky patient who is hypotensive and has low blood pressure. Rehydration therapy, we're usually going to divide that into components. And the bottom line on this is you will go into a lot of clinics who will say, okay, I'm going to put this dog on 2 times maintenance and call it a day. And that is lazy medicine. Do I do it? Yep. Every once in a while, I will do it. It is much better if you can sit down and think through your fluid therapy prescription, because fluids are a drug. You're not going to be like, I don't know, put the dog on, 100 milligrams of Lasix and it's a 4-pound Chihuahua. So you really should try and be a little bit more prescriptive. I'm not trying to complicate anybody's life, but I do think it's better for your patients if you can divide it up into these 3 things. So the deficit is how dehydrated is the patient when they come to you. So let's say you look at a dog that was locked in the basement for 4 days, and he comes in and his eyes are sunken and he's got a prolonged skin tent and his gums are all tacky. That's a patient who's probably 10 or 12% dehydrated. And it's a little bit beyond what we're trying to approach today to assess levels of dehydration. But suffice it to say, deficit is what they come to you with that you're going to correct. Maintenance is, let's say, a dog that is, a parvo puppy. He's not able to meet his fluid therapy needs to stay hydrated because his guts are in rebellion. So maintenance is what a dog needs just sitting in a cage to replace fluids that they normally would get through eating and drinking. And then ongoing losses are things like, again, using the parvo puppy example, let's say the dog comes in and he's dehydrated, and you calculate how much to give him for that. And you're giving him maintenance fluids, but he has 3 episodes of vomiting and 4 episodes of blowout diarrhea overnight. You're not going to keep up with his hydration needs if you don't put that into your fluid therapy prescription. And yeah, for a lot of patients, 2 times maintenance is fine. But for something like a little, 3-kilogram parvo puppy, it's not going to be anywhere near enough. Or another really good example is if you see a blocked cat and you unblock them, they're going to have what's called a post-obstructive diuresis for at least 24 hours after that. And they will be putting out 100 mils per kilo per hour of urine. And just your standard, maintenance or maintenance and a half or 2 times maintenance is not going to cut it for those guys. So ongoing losses are things like, the post-obstructive diuresis, loss from abdominal drains, continued vomiting and diarrhea, stuff like that. But really, what I would urge you to do is develop a plan. I'm not trying to make it complicated. I'm just trying to make it so you tailor your fluid prescription to what the patient needs. So let's talk just a little bit about shock. The shock dose of fluids, you will see different variations of this, but this corresponds to basically how much blood the patient has. And that's 90 mils per kilo in dogs and 60 mils per kilo in cats. Again, you're going to see different numbers. This is not delivered all at once. This is kind of, think of it as your bank of crystalloid fluids like LRS that we can use to give our patients who are in shock. So let's say I have a GDV that comes in and it's 40 kilos, and he comes in and we document that the dog's very shocky. So 40 times 90 is 3,600. So that's about 4 liters of fluids. That's sort of the maximum I really want to give over time, over an hour or 2. And I'll usually give a quarter-ish or so of that, same thing with cats, and then assess their response. So let's say this GDV comes in, he's got low blood pressure, I've got 4 liters to play with. I'll drop a liter of fluids into him as quickly as I can and reassess my response. So what does a response to that look like? Well, in a dog, often their heart rate will improve. So they often come in with a very high heart rate. That'll hopefully go down. They'll start to get blood out to their extremities. So their feet may be very cold. So maybe their feet will warm up. Improvement in body temperature, and then things we can measure, like does their blood pressure improve? Cats are a different story. Cats tend to not have a rapid heart rate when they are in shock, so that's a little bit less of a good indicator. But same thing, where if I get a hit by car cat who looks crummy, low body temperature, let's say we measure lactate, which is something that gives us an indication of how poorly oxygenated the tissues are, and the lactate is elevated, I'll give about maybe 10 to 15 mils per kilo and assess response. So here's a sample fluid therapy algorithm. 1, evaluate for evidence of cardiac disease. So just, is there a murmur? Is there a history of heart disease? And then we'll give about a quarter of the shock dose of fluids as fast as possible. And that doesn't mean set the pump to 999. That doesn't mean, over an hour. That really means for a true shock patient, as fast as you possibly can. So that's about 10 to 20 mils per kilo of crystalloids. That's roughly a quarter of the shock dose. And then colloids we don't use. So cats, because they have to be special, a cold cat, a hypothermic cat, is not going to be able to adjust and monitor their blood pressure as well as a normotensive cat. So with cats, you really want to focus on warming them up as part of your shock treatment. Dogs, it's important. It's just not as important in a cat. So I'm really cautious with fluids in hypothermic shocky cats because it's very easy to give them more fluids than their heart can handle. So just if you're going to take one thing home from this is if you have a trauma cat, a shocky cat, septic cat, whatever, yes, they need a little bit of fluids, but you also need to try and get their body temperature back online. And then we go back to our patient and say, okay, what is their blood pressure? What is their heart rate? Is their temperature improving? Target blood pressure for a cat, and this may be a little more advanced than you need, but if they're really, really cold, 98 degrees Fahrenheit, I have a little bit of a lower target blood pressure than the 90 millimeters of mercury that I use in a normothermic cat. So I wouldn't worry too much about that. And then if they're still in shock, we're going to take from that bank of, let's say, going back to our GDV patient, we had 4 liters to play with. So it'd be like, okay, that 1 liter didn't really get me where I wanted to go. His, heart rate's still high, blood pressure's still low. Let's do another liter and see what that does. And then for septic patients, if you've given them a full shock dose of fluids, this start talking about a pressor agent like I talked about to constrict blood vessels a little bit. Don't worry about that part too much. The route for a lot of patients who are in the hospital, we're going to go by the IV route for sure. For shocky patients, we're going to go IV route. Sub-Q is subcutaneous fluids. That's ideally, if you see a dehydrated patient, they should be on IV fluids. Sometimes the world does not allow that. PO means per os, that's the oral route, and IO means intraosseous, and that's where we put a needle right into the medullary cavity of the bone. Great for neonates, great for exotics, that little kitten that comes in that is, septic. You often can't get a catheter in those guys. IV is kind of the most common route that everybody is used to. And then sub-Q would really be either very mild dehydration or ideally as a hedge against dehydration, cat that vomited once, it looks fine on your physical. Sub-Q fluids have never saved anybody's life. So yeah, they're great. They are largely medical theater, but still they have their place.
Dr. Johnson?
Yes, sir.
We've got about a 5-minute warning.
Okay, I'm gonna wrap it up. This might even be the last slide. If not, I'm gonna make it the last slide. So, okay, no thank you. I'm so sorry. Okay, I'm gonna don't put dextrose sub-Q. One thing that I would like to say is, does the patient need IV fluids? Just because you got a patient in the hospital, they don't all need IV fluids. Fluid type, I'm not going to really get into too much. That's sort of the advanced course. Hypertonic saline is a special kind of fluids that we'll often use for head trauma patients. So remember that one. That's pretty good. Dose. So here's that 3-part plan I was talking about. One is the deficit, how dehydrated they are when they come in. We'll usually correct that within about 24 hours or so. And the way you figure that out is, well, we'll say the time. Maintenance, usually 60 mils per kilo per day. And the rough starter is a mil per pound per hour. Usually we use kilos, but this is a handy little thing that I'll use if it's a busy day and I just got to get a patient on IV fluids and it's a 50-pound dog and he's not critical. He's not in shock. He's not dying. We'll do 50 mils an hour, mil per pound per hour. And then ongoing losses, as I talked about. And that is it. Look, I'm only like 7 minutes over, but that is it. Thank you guys for your patience. I hope it wasn't either over or under anybody's level, but that is our top 5.
Thank you so much, Dr. Johnson, for sharing your expertise and valuable tips with us. We're going to open it up now for a few questions from our attendees. Please feel free to drop your questions in the chat, and we'll get to as many as possible. All right, we're looking to see. Okay, here's our...
And hey, JD, can you do me one favor?
Yes, of course.
My email is very simple, and I'm happy to give it out to people if they have follow-up questions.
Okay.
It's tony@vin.com. So TONY@VIN.com.
Mm-hmm. Okay, we're putting that in the chat, and that will also be shared in the email with everybody so that if you have any other questions, you can email Dr. Tony and he will address your question. All right, we do have a couple here, Dr. Tony, that we're going to run through quickly.
Okay. Let's see. I'm just scrolling down. It says the end. Okay, frequently might use subsequent serial UAs when assessing and administering fluid therapy. Oh, okay. So I think I understand what they're going for. Here, I'll answer. Oh, start live answer. Ah. So it's not so much serial UAs. It's mostly urine-specific gravity. And it's usually kind of once a day. Like I like to get a morning sample and evaluate that and see how it's doing. For hypovolemic shock, urine isn't really part of the isn't part of the equation. So hopefully, I hope that answers that. And let's see. Best way to develop a fluid therapy plan. Well, really, a lot of it's going to depend on where you are, what your capabilities are. But if you look at the deficit, it's never going to be perfect. It is never going to be perfect. I've had lots of patients where I've either underdone it or overdone it. But if you kind of make a crude assessment of what their dehydration deficit is, and then you meet their maintenance needs, and then you are at least incorporating ongoing losses, that's going to be pretty good. There's lots of other things that you can use, like body weight. Patients who are dehydrated when they come to you and you rehydrate them, they should gain some weight because they've lost water weight. Looking at electrolytes. So there's about 30 little things you can look at, and you don't have to look at all of them, but as many of those variables as you can look at, the better. Favorite vasopressors. Oh, Luke is going for the advanced class. So we don't use them very often. Norepinephrine seems to be the one that's kind of become the favorite. I sort of grew up in the dopamine era, but norepi is the one that we use most commonly. Other than acidemia, other patient factors that might make you prioritize one over the other. No, I mean, norepi's it. For a while, vasopressin was, your statement about acidemia is profound, because that's the one that's supposed to work the best when there's a metabolic or any sort of acidosis. The problem is, last time I checked, it was ungodly expensive, so I haven't used that in several years. Okay, cool. JD, I'm going to hand it back to you because I got to go back to the ER.
Okay. Once again, a big thank you to Dr. Johnson for his time and insights today. On behalf of Fear Free and our friends at the Veterinary Business Management Association, we also want to extend our gratitude to all of you for attending this Top 5 and 15 webinar.
Yeah,
we hope you found it helpful, and we encourage you to apply these techniques in your future practice to help reduce FAS in your patients. As a reminder, the recording of today's session will be sent to your email within 2 weeks, so keep an eye out for that. Be sure to follow us on social media at Fear Free Pets. For more educational content and updates, we're excited to continue bringing you webinars in the future. Dr. Johnson is signaling he has to go. Thank you so much again.
Yep. Thanks, Johnson. JD. You did great. I appreciate it. Bye, guys. Grow up big and strong.